Non-tuberculous mycobacterium infection Aerbium intracellular MAI complex. In absence of HIV, MAI presents as a cup/sputum in an ordered pattern with COPD. Using positive sputum cultures consider colonization. Treat only if the colony grows repeatedly and respiratory symptoms are apparent and X-ray is abnormal. Use azithromycin or clarithromycin and rifampin or ifabutin and ipamutol. Rapidly growing mycobacteria M. abscessus and M. fortuitum. Infect skin and soft tissue, especially following surgery or trauma. Grows in 5 to 10 days. Lives in water and soil. Look for a question each time a colonized water line in a dental layer. M. Kansai Sasi, lung disease similar to TB, 90% with cavity lesions. Lung disease, same indications as for MAI. Allergic bronchopulmonary aspergillosis, ABPA, is hypersensitivity of the lungs to fungal antigens that colonize the parenchymal tree. ABPA occurs almost exclusively in parents with asthma and a history of atopic disorders. What is the most likely diagnosis? Look for an asthmatic patient with recurrent episodes of bronchial sputum and transient infiltrates on chest X-ray. Cough, wheezing, hemoptysis, and sometimes bronchitis occur. Diagnosis testing is as follows: peripheral eosinophilia, skin test reactivity to aspergillus antigens, precipitating antibodies to aspergillus on blood test, elevated serum IgE, pulmonary infiltrates on chest X-ray or CT. Treatment is as follows: oral steroids, prednisone for several cases, severe cases, or itraconazole for recurrent episodes, while omalizumab to prevent exacerbations, particularly in those with asthma, untreated ABPA causes progressive lung fibrosis or bronchiectasis. An inhaler cannot deliver a high enough dose of steroids to be effective in ABPA. Use oral steroids. COVID-19. In 2020, COVID-19 emerged and quickly escalated into a global pandemic. At the time of printing, management is not clear. Here is what is known. COVID-19 is an infectious disease caused by coronavirus SARS-CoV-2. While most coronaviruses cause minor respiratory illnesses, examine the common cold. SARS-CoV-2 is one of the few that can cause serious disease and death. The others are Middle East Respiratory Syndrome (MERS) and Severe Acute Respiratory Syndrome (SARS). After the SEP2CK exam addresses COVID-19 the next year or two, the most likely question will be about diagnosis. Fever, dry cough, and dyspnea without sneezing, runny nose, and sputum. Cause, smell, and taste central to answering the question. Testing PCR, most accurate test. Chest X-ray will show abnormalities but is non-specific. Antibody testing does not diagnose acute disease. Inflammatory markers examine ferritin, D-dimer, LDH, and CRP. Management respiratory isolation. Steroids such as dexamethasone for severe ill patients with bacteria. No proven antiviral therapy at this time. Remdesivir, a broad-spectrum antiviral, has been approved for treatment of hospitalized COVID-19 patients aged 12 or older who require oxygen therapy or mechanical ventilation. Solitary pulmonary nodule. The patient has a solitary pulmonary nodule. The key issue for step 2 CT regards biopsy. Then do you answer biopsy the lung lesion? Biopsy enlarging lung lesions, especially enlarging rapidly lung lesions. For all lung lesions, the best initial step is to compare the size with old X-rays. Benign versus malignant pulmonary nodule. Benign, malignant. Benign age less than 30, no change in size, non-smoker, smooth border, small less than 1 cm, normal lung, no adenopathy, central calcification, and normal PET scan. Malignant age greater than 40, enlarging smoker, spike-related spikes, large greater than 2 cm, atelectasis, yes adenopathy, but eccentric calcification, abnormal PET scan. Biopsy all enlarging lung lesions, particularly if they are rapidly enlarging. The figure 4.15 chest X-ray showing solitary lung nodule. Diagnostic testing and treatment are as follows. High probability lesions. Dissection of the lesion when many of the malignant features described are present. Sputum cytology, needle biopsy, and PET scan are not used. Negative tests are likely false negatives. Intermediate probability lesion. The gray areas are inconclusive features of the solitary pulmonary nodule. Example age 30 to 40. Sputum cytology. Negative cytology does not exclude malignancy. Microscopy or transthoracic needle biopsy is the most appropriate next step. In the most patient with intermediate probability of malignancy, central lesions use bronchoscopy, peripheral lesions use transthoracic biopsy. Lung cancer screening indicated by chest CT, indication by chest CT, 20 year tobacco history, age 50 to 80 years, and not quit in last 15 years. A PET scan sensitivity 85 to 95% can identify without a biopsy whether the contents of the intermediate risk lesion are malignant. Malignancy has increased uptake of diet glucose. Negative PET scan points away from malignancy is most accurate with larger lesions. VATS is more sensitive and more specific than all the other forms of testing. Bone section in the operating room allows for immediate conversion to an open thoracoscopy and lobectomy if malignancy is found. PET scan is the most accurate with larger lesions greater than 1 centimeter. Tip on exam questions, remember the clear answer must be present. If you have an question about the test diagnosis test for an intermediate lesion provides testing options that are not clear, the adverse effect will be clear. The most common side effect of transthoracic biopsy is pneumothorax. Interstitial lung disease, pulmonary fibrosis. Pulmonary fibrosis or idiopathic fibrosing interstitial pneumonia is thickening of the interstitium septum of the lung between the alveolar space and the alveolus. Fibrosis interferes with gas exchange in both directions. Fibrosis can be idiopathic or secondary to a large number of inflammatory conditions, radiation, drugs, or from inhalation of toxins. All of them thicken the septum. Only some have white blood cells infiltrated with lymphocytes or neutrophils. Chronic conditions lead to fibrosis and thickening. Causes of pulmonary fibrosis are as follows: idiopathic interstitial pulmonary fibrosis, radiation, drugs, bleomycin, busulfan, imidazole, methotrexate, hydrochlorothiazide, and methotrexate. Inflammatory infiltration with white blood cells is reversible, treatable, whereas fibrosis is irreversible. Types of pneumoconiosis: exposure disease, cold, coworker pneumoconiosis, sandblasting, rock mining, tunneling, silicosis, shipyard workers, pipe fitting, accelerators, asbestosis, cotton bucinosis, electronic manufacture, berliosis, and morty sugarcane biasosis. All forms of pulmonary fibrosis, regardless of etiology, present with dyspnea, worsening on exertion, fine rays or crackles on examination, loud P2 heart sound, clubbing of the fingers. Methotrexate causes fibrosis of both liver and lung. Diagnostic testing includes pulmonary function test, restricted lung disease with decrease of everything is proportionately FEV1, FVC, TLC, and residual volume all decrease, but since everything decreased, FEV1 by FVC ratio will be normal. DLCO decreased in proportion to the severity of the thickening of the alveolar septum. Chest X-ray, best initial test. High resolution CT scan, more accurate than chest X-ray. Lung biopsy, most accurate test shows granulomas and berliosis. Echocardiography often shows pulmonary hypertension and possibly right ventricular hypertrophy. Figure 4.16, severe long-term intestinal fibrosis produces thickened walls between alveoli that give the appearance of honeycombing. Treatment: most types of interstitial lung disease are treatable. Treatable treatment includes prednisone, a biopsy shows WBC or inflammatory infiltrate. Steroids of all the causes of pneumoconiosis. Berliosis is the most likely to respond to steroids due to presence of granulomas, a sign of inflammation. If patients respond to steroids, switch to azathioprine for long-term treatment to get them off steroids. If no response to steroids or azathioprine, try cyclophosphamide, pirfenidone, and nintedanib to slow the rate of fibrosis. Pirfenidone, an antifibrotic agent, inhibits collagen synthesis. Nintedanib, a tyrosine kinase inhibitor, blocks fibrinogen growth factors and inhibits fibroblast. And acetylcysteine does not help lung disease. Sarcoidosis. Sarcoidosis is an idiopathic inflammatory disorder predominantly of the lungs, but can affect most of the body. It is common in African American women. What is the most likely diagnosis? Look for a young African American woman with shortness of breath on exertion and occasional fine rales on lung exam, but without the feeling of asthma. Erythema nodosum and lymphadenopathy, either on examination or especially on chest X-ray, will hand you the diagnosis question. Sarcoidosis also presents with pituitary gland enlargement, facial palsy, heart block, and restrictive cardiomyopathy. sinus involvement, iritis, and uveitis. Although liver kidney granulomas are very common on autopsy, they are rarely symptomatic. Tip answer: sarcoidosis when a chest X-ray or CT shows hilar adenopathy in a generally healthy African American woman. Figure 4.17 Sarcoidosis with bilateral hilar adenopathy. Diagnostic testing is as follows: chest X-ray, a best initial test, shows hilar adenopathy in almost all cases. Pancreatic involvement and adenopathology. Lymph node biopsy, most accurate test. The granulomas are non-calciating. Hypercalcemia 5%, granulomas and sarcoidosis make vitamin D. Elevated HCl level 60%. Hypercalciuria 20%. PFT distributed along these decrease FeV1, FVC, and TLC with normal FeV1/FVC ratio. Treatment is prednisone, drug of choice. Few patients fail to respond. Asymptomatic hilar adenopathy does not need to be treated. Bronchial failure lab shows an elevated level of helper cells.